Jivak, are you there?
এক মিনিট কৌস্তব, আমি আছি এখানে, আমি রিতমের সঙ্গে কথা বলছি, এক মিনিট। হ্যাঁ কৌস্তব, হ্যালো।
হ্যাঁ, শুনতে পাচ্ছ?
হ্যাঁ হ্যাঁ,
আচ্ছা,
এক মিনিট, তবে একটু টেস্টিং করে নি অডিওটা।
জীবক শোনা যাচ্ছে?
হ্যাঁ একদম পরিষ্কার,
ক্লিয়ার? ওকে,
একদম ক্লিয়ার।
কি শুরু করবো না?
স্ক্রিনও দেখা যাচ্ছে না, একটু দাঁড়াও।
হ্যাঁ, ওকে ওকে, ঠিক আছে,
বলে দেবো আমরা।
হুম হুম।
গুড ইভিনিং, শোনা যাচ্ছে তো রিতম, জীবক?
হ্যাঁ হ্যাঁ, অভিষেক
হ্যাঁ দাদা একদম পরিষ্কার।
ঠিক আছে।
Jivak, should we start?
হ্যাঁ আমার মনে হয় স্টার্ট করা যেত না। অভিষেক দা?
Hello?
হ্যাঁ, of course we can start.
Okay, কৌস্তব, let's start.
36 we can start.
Okay. So, good evening, everyone. This is the second class of our clinical oncology course on breast cancer. And today's chairperson is with us, Dr. Shamrat Dotto. He will announce our next speakers and our speakers. So I would like to invite Dr. Shamrat Dotto. Please start with the webinar. Thank you, sir.
Am I audible and visible?
Yes.
Sorry. Yeah.
I can't hear you. Am I audible and visible to everybody?
Yes, but your voice is a bit low. Can you increase the volume, please?
Is it okay now?
Yeah, it's better. Thank you. Thank you.
Better? Yeah.
Yes. Yeah.
Okay. So we are in the second part of the module first of our AROI session. So today's topic is on breast cancer. So we have three speakers today back to back, and we will be highlighting on various aspects of the breast cancer. So first of all, there will be a talk on neoadjuvant and adjuvant treatment paradigm in breast cancer, followed by the endocrine treatment in breast cancer, and followed by the systemic therapy in advanced metastatic breast cancers. So to start off without any delay, I would like to invite Dr. Ritam Joardar, who is a clinical tutor in Arjikar Medical College Department of Radiotherapy. He will be highlighting on all the aspects of the neoadjuvant and adjuvant treatment paradigm in breast cancer, the basic concepts, and he will be also highlighting about the toxicities and how to manage and thereafter. So I hand over to Dr. Ritam. Dr. Ritam, please start.
Thank you, Dr. Datta. Am I clearly audible to everyone?
Yes.
Okay, thank you. Good evening, everyone, and welcome to this session of Clinical Oncology online course. At the very outset, I must thank AROI West Bengal chapter for this great initiative and for having me today to discuss this topic, that is neoadjuvant and adjuvant treatment paradigm in breast cancer. Now, in our previous session, we have already learned about the primary treatment, that is surgery, BCS or mastectomy, and adjuvant radiation therapy. And my next speaker, Dr. Abhishek Basu, will be talking on adjuvant endocrine therapy also. So my slides will be essentially centered around these key areas, that is advances of adjuvant chemotherapy and adjuvant HER2 targeted therapy, principles of neoadjuvant therapy, decision making of neoadjuvant or adjuvant therapy, use of adjuvant bisphosphonate therapy, and administration and safety of major systemic therapy agents in adjuvant setting, that is anthracycline, taxane, and trastuzumab. In the over next 40 minutes, the name we are going to utter most of the time is of Dr. Bernard Fisher. So Dr. Fisher was an eminent surgeon, cancer surgeon of US, and was the chairperson of NSABP group, that is National Adjuvant Surgical Breast and Bowel Project. Dr. Bernard Fisher actually pioneered the adjuvant treatment in breast cancer by challenging the century-old concept of William Halsted, where Halsted told that breast cancer is essentially a localized disease guarded by the anatomical barriers and lymphatics, and therefore more aggressive surgery will result in more disease control and less treatment failure. However, in his landmark paper published in Cancer 1977, Bernard Fisher have shown that in spite of radical surgery, the treatment failure at 5 years and 10 years was high, almost 40% to 50%, and it was almost 80% or above in those patients having more than 4 nodes. Therefore, Fisher claimed that breast cancer is predominantly a systemic disease at its very onset, with subclinical micrometastasis resulting in treatment failure, and that's too in distant size. Later, a meta-analysis by EBCTCG, that is early breast cancer trial collaborative group published in NEJM 1995 have shown that addition of radiotherapy to surgery also doesn't improve the overall survival, the long-term overall survival much. It is only 1.4% benefit in case of node-positive disease and 0.2% benefit in node-negative disease. Therefore, they felt a dire need of adding something more to surgery and radiotherapy for better disease control and less treatment failure. And at the later half of 20th century, uh, NSABP group led by Dr. Fisher, they started using the available chemotherapy drugs in adjuvant setting. Those were thiotepa, then melphalan, and 5-FU, alone or in combination. And among these NSABP trials, they found that in NSABP 05, there was much less treatment failure using melphalan, that is ALPAM, and better DFS, particularly in premenopausal group. The treatment failure was only 3% in melphalan group compared to 30% in control group. Encouraged by these results, the Milan group of Italy, led by another famous oncologist, that is Giovanni Bonadonna, they tried a CMF regimen in adjuvant setting, that is cyclophosphamide, methotrexate, and 5-FU. Though in this CMF regimen, the cyclophosphamide was actually an oral drug, and this was a monthly regimen for almost 12 cycles. So they found that distant recurrence was more common than locoregional recurrence, and treatment failure was more common with patients having more than equal to 4 nodes. And they also found that CMF significantly reduced the treatment failure, especially in premenopausal group. By that time, in early 70s, anthracyclines were used in metastatic setting for breast cancer, but now people have started using anthracyclines in adjuvant setting also. And the same Milan group of Italy, they have tried to different anthracycline containing regimens, that is FAC, that is 5-FU, adriamycin, and cyclophosphamide, and compared it to FEC, that is 5-FU, epirubicin, and cyclophosphamide. And they found that both are similarly efficacious to improve the treatment disease control, both at local site and distant site, with less toxicity with FEC arm. The neutropenia, nausea, vomiting, as well as cardiotoxicity was less common in FEC arm. So having all this data, EBCTCG group came out with their first meta-analysis in 1988, and they have shown that 5-year mortality was much less in patients less than 50 years of age group who had tamoxifen. Then it was also less in those patients above 50 years of age who are treated with chemotherapy in adjuvant setting. Polychemotherapy was more efficacious than single agent chemotherapy, and chemotherapy of shorter duration, that is 4 to 6 months, was equally efficacious to longer duration, that is 8 to 24 months, with less toxicity. Later, NSABP group conducted another trial comparing AC, that is doxorubicin cyclophosphamide regimen, against CMF, the standard of care, and found that the shorter duration AC regimen, that is of 2 months, was similarly efficacious to 6 months of CMF regimen. And NCIC MA5, they compared FEC regimen with CMF and found that FEC is better efficacious than CMS in terms of survival as well as disease control. In 2001, the French group FASG, they compared a newer regimen, that is FEC 100 for epirubicin was used at a higher dose, 100 milligram per meter square, compared to classical FEC regimen of Levin, that is epirubicin of 50 milligram, and they have found that using chemotherapy drug with at a higher dose is more efficacious than using at a lower dose. So based upon all this data, National Institute of Health came out with a consensus statement regarding the adjuvant chemotherapy in 2000. And this statement said that adjuvant hormonal therapy should be recommended to all those patients where the base tumor is hormone receptor positive, regardless of other risk factors. The only possible exception is probably the premenopausal women with a smaller tumor size that is less than 1 centimeter, and also in those elderly patients
నెయిల్ పాలిష్ కావాలంట
who have a
పాలిష్
history of VT, because venous thromboembolic episodes, because tamoxifen is notorious to cause VT on long-term use. The next recommendation in this consensus was
ఖాళీ పేజీలో రాసుకోవాలి
kindly mute your okay. The next recommendation in this consensus was adjuvant polychemotherapy should be recommended in majority of patients with localized breast cancers, regardless of any other adverse factor. And particularly, the impact is more in patients with lymph nodal metastasis or tumor size more than 1 centimeter in diameter. So since then, it is a standard practice to offer adjuvant chemotherapy in lymph node positive patients and in tumor size more than 1 centimeter. However, again, in tumor size less than 1 centimeter or lymph node negative cancers remain a gray area where the decision to consider chemotherapy should be individualized. And to answer this dispute, Dr. Fisher made a retrospective analysis of all the available 5 NSABP trials, and he found that chemotherapy and tamoxifen both increase the ETS recurrent-free survival, both in ER positive or ER negative patient, even if the T size is less than 1 centimeter or there is N0 disease. However, the recurrence is much more in larger tumors, that is T size more than 1 centimeter, or younger patients who are less than 50 years of age group. So by the end of that millennium, we had anthracycline-based chemotherapy, that is AC, FEC or FSC and CMF as a standard of care adjuvant therapy. But at the onset of new millennium, people started using taxanes. So two major trials were CalGB 9344, who used AC, standard AC, that is doxorubicin cyclophosphamide 3 weekly, followed by paclitaxel 3 weekly, and found an improved 5-year disease-free survival and overall survival, particularly in hormone-negative patients who didn't have tamoxifen. And another trial was CalGB 9741, who tried dose-dense AC followed by paclitaxel, where the frequency of cycle was 2 weekly, and found that dose-dense regimen increases the 4-year disease-free survival and overall survival. The NSABP B28 and also confirmed the findings of previous CalGB trial. Another new regimen came into practice, that was TAC, that is TAC regimen, which was tried in BCIRG 001 trial against FAC regimen, and found that TAC regimen is more efficacious than FAC regimen. Then EBCTG meta-analysis, the next update came in Lancet 2005 and found that 6 months anthracycline-based polychemotherapy reduces the annual breast cancer death rate in all age group, irrespective of other factors. Now, another trial, that is PACS01, they tried a newer regimen, that is 3 cycles of FEC followed by 3 cycles of paclitaxel, and found that this regimen is better, improving 5-year survival, especially in postmenopausal group and more than 50 years of age, when compared to standard 6 cycles of FEC regimen. The next important trial was ECOG 1199 with 2 updates in 2008 and 2015, and they tried 4 AC regimen followed by a different schedule of taxane, that is docetaxel 3 weekly versus paclitaxel 3 weekly versus paclitaxel weekly, and they found that a better DFS and overall survival with paclitaxel weekly and docetaxel 3 weekly regimen. Particularly, paclitaxel weekly regimen was more efficacious in TNBC patients. But gradually, people were also concerned about the cardiotoxicity of anthracycline. So they tried a newer regimen, that is TC, paclitaxel and cyclophosphamide versus doxorubicin and cyclophosphamide in US trial 9731, and found that TC regimen is having a better DFS and overall survival in both older and younger patients. The next trial by Miguel Martin in JCAM 9805 tried TSC TAC regimen versus FSC in N0 high risk patients and found that TAC regimen improves DFS in this low risk group also. Finally, EBCTCG meta-analysis. The next update came in Lancet 2012, and they found that standard CMF regimen is equivalent to standard AC regimen, 4 cycles, and regimens with significantly higher dose of anthracyclines or other chemotherapy regimens are more efficacious than regimens with chemotherapy other than standard 4AC. Those are higher or more aggressive than standard 4AC, are more effective, like FSC, FEC, or 4AC followed by 4-taxane. And 10-year overall survival got improved with all kind of chemotherapy. Then NSABP B36, they compared 6 cycles of FEC 100 versus 4 cycles of standard AC regimen and found there is no added advantage of 6 cycles FEC with greater toxicity. So therefore, the 5FU is omitted from this FEC regimen, and nowadays we can practice AC regimen or EC regimen as a standard of care. Finally, the latest CREATEX trial, which used adjuvant capecitabine in TNBC patients after neoadjuvant anthracycline taxane-based chemotherapy. And they found that using capecitabine at adjuvant regimen in TNBC patient, 5-year DFS was improved. It was almost 69.8% versus 56% in control group. And overall survival was also improved by almost 8.5%. So based upon all this data, current NCCN guideline that recommends the following regimens for HER2 negative group, that is dose dense AC followed by paclitaxel every 2 weekly, dose dense AC followed by weekly paclitaxel, then only docetaxel and cyclophosphamide TC regimen. In triple negative breast cancer, we can add capecitabine in adjuvant setting. Other useful regimens are dose dense AC, CMF, then AC followed by weekly paclitaxel, and also TAC regimen. So these were all about the chemotherapy part. Now we are coming to advancement in adjuvant anti-HER2 therapy. The first important trial in anti-HER2 therapy in adjuvant setting was Big 0101 HERA trial, where they tried trastuzumab for 1 year in adjuvant setting after local therapy and found improved 2-year DFS and overall survival. And trastuzumab found FDA approval in adjuvant setting based upon the combined analysis of 2 important trials, that is NSABP B31 and NCCTG trial. In both these trials, trastuzumab was used in adjuvant setting with sequential anthracycline taxane arm, and trastuzumab was started either concurrently with the taxane or after completion of the chemotherapy. And both these trials have found improved overall survival and disease-free survival. However, PAC-04 trial, which used sequential trastuzumab for 1 year after completion of chemotherapy, didn't found any significant reduction in relapse risks. Another trial, that is BCIRG 006, compared the standard of care AC followed by TH versus TCH, where the C arm is actually carboplatin. So this platinum containing arm, that is TCH, was found to have similar efficacy but less cardiotoxicity and secondary leukemia compared to AC followed by TH. FINHEART trial used a shorter course of adjuvant trastuzumab, that is 9-weekly cycle. Then FAIR trial also used a de-escalated strategy, that is trastuzumab of 6 months versus standard of care 12 months, but failed to show any improvement. Then the later update of HERA trial at 2013 found that there is no benefit of 2 years of trastuzumab therapy compared to 1 year of trastuzumab therapy in adjuvant setting. The latest trials after 2015 are affinity trial, where pertuzumab was added to adjuvant trastuzumab uh, and found to have efficacious to improve the survival. Then extended trial, where there was 1 year of extended anti-HER2 therapy, neratinib oral 240 milligram once daily was used after completion of chemotherapy and trastuzumab in adjuvant setting to reduce the local and distant relapse. Then Catherine trial, where TDM1 was used after NSCT and trastuzumab if there is any residual tumor. And Persephone trial finally found that 6 months therapy of trastuzumab is non-inferior to 12 months therapy. So short course trastuzumab is similarly efficacious to 12 months therapy. And based upon all these trials, NCCN currently recommends adjuvant HER2 targeted therapy uh, in all patients having HER2 positive tumors greater than 1 centimeter. Therefore, again, there is a gray area of tumor size less than 1 centimeter. And to address this problem, there was a systemic analysis published in NEJM in 2015, where they found that adding paclitaxel and trastuzumab for node negative stage 1 HER2 positive disease, there is a risk of early recurrence is only 2%. So there is a reduction of risk of early recurrence, and based upon this trial, NCCN panel suggests that trastuzumab and chemotherapy should also be used in HER2 positive node negative tumors where the tumor size is less than 1 centimeter but more than 0.6 centimeter, because the tumors less than 0.6 centimeters were less represented in this trial. So based upon all this data, the current recommendation from NCCN is for HER2 positive patients are paclitaxel plus trastuzumab, then TCH regimen, that is docetaxel, carboplatin, trastuzumab, then trastuzumab and pertuzumab in adjuvant setting, then adotrastuzumab emtansine, that is TDM1 in adjuvant setting when there is a residual tumor after using sequential anthracycline taxane plus trastuzumab. There are other useful regimens also, like AC followed by TH, then AC followed by docetaxel, trastuzumab, and pertuzumab. So now, by this time, we understood that we have anthracycline and taxane-based sequential regimen. That combination of anthracycline and taxane together as a concurrent regimen. We have trastuzumab for HER2 positive disease, even if it is less than 1 centimeter. But when to offer these tumors and to whom? There are two main questions regarding patient selections: who needs treatment, and we must avoid under and over treatment based upon prognostic factors, and which treatment is ideal for which patient. So we should individualize treatments on based upon different predictive factors. So available clinico-pathological prognostic factors are tumor size, like there is high risk of recurrence if the tumor size is more than 1 centimeter, then lymph nodal status, if it is more than or equal to 4 nodes, the risk of recurrence is high. Then grade, if it is more than if it is grade 3, then recurrence risk is high, but in grade 1 it is low. Grade 2 is a intermediate area. Then ERPR and HER2 receptor expression and Ki67 expression, that is the molecular profile, and based upon which we have the luminal group, then HER2 enriched group and basal group. and also presence of lymphovascular invasion. So lymphovascular invasion is an independent prognostic factor for local and distant recurrence. So based on all these prognostic factors, we have certain prognostic algorithms like predict from a National Health System, NHS, the Nottingham Prognostic Index, and Adjuvant Online. And you can use this predict tool free of cost. You can put the parameters of your patients. Like in this example, the age is 69. It's a postmenopausal patient with ER positive, HER2 negative status. Ki67 is positive. Tumor size in 2 centimeter. Tumor grade is 3, and it was detected by symptoms, and there was no node positivity. And now if you choose your treatment options like 5 years of hormone therapy, with surgery, the overall 5 years survival was only 84%. Adding hormone therapy, it increases by another 3%. Then adding chemotherapy to hormonal therapy, the 5-year overall survival increases by 1.4%. And adding bisphosphonate therapy to hormone and chemotherapy, it increases the 5-year overall survival by 0.9%. So you can use this predict tool to predict the efficacy and the final prognosis, the survival of the therapy you are going to offer your patients. Apart from this tool, there are other guidelines to help us to decide the right treatment for right patients, and these are St. Gallen's International Consensus, NCCN, ASCO, and ESMO. So let's see what St. Gallen International Consensus says about ER positive, HER2 negative breast cancer patients. So for stage 1, T1A and B disease, they recommend hormonal therapy and no chemotherapy. Whereas for stage 3 patients, they recommend chemotherapy in addition to hormonal therapy, but never concurrently. They should be used sequentially. The in-between group, that is stage 1 T1C and stage 2 group, for ER positive patient, you must offer hormonal therapy, but regarding chemotherapy, you need to individualize decisions based upon the clinico-pathological factor we have already discussed. And even if it is indeterminate, then you should use the genomic signatures and also patient preferences. So if it is a ER positive, HER2 negative disease, that is luminal disease, and there is clear indication of chemotherapy, omitting chemotherapy, like if it's all low risk, high level of hormone receptor expression, grade 1, node negative, and low Ki67 index, then you should offer hormonal therapy alone. But if it is high risk patients like low level of hormone receptor expression, then grade 3 node positive and high Ki67, you should add chemotherapy along with hormonal therapy. But if there is a mix up of these risk factors and there is no clear indication for classical risk factors, some may be of high risk and some may be of low risk of recurrence, then you can take the help of genomic signatures. So what are the first generation genomic signatures? One is 21 gene oncotype DX, used for T1 to pathological N0 hormone receptor positive cases, and based upon Taylor-X trial, there are certain recurrence risk scoring. If the score is less than 26, there is no benefit of adding chemotherapy to hormonal therapy, except in a single group, that is less than 50 years of age group with a recurrence score of 11 to 25. Now, if the recurrence risk is 26 to 30, you may consider adding chemotherapy to hormonal therapy, that too based upon the other clinical pathological factors. And if the recurrence score is more than equal to 31, then addition of chemotherapy to endocrine therapy is must. The next first generation genomic signature is 70 gene MAMA print, which is also used for T1, 2 or operable T3 disease, but it is also used for node negative patients, where Oncotype DX is only used for node positive patient. MAMA print can be used for 1 to 3 node positive patients also. So Based upon MINDAC trial, there are 4 groups of MammaPrint result. One is clinically low risk, genomic low risk group, where no chemotherapy is recommended, only hormone therapy. And another group is clinically high, genomic high, where chemotherapy is must for with endocrine therapy. But the in-between groups are again a disputed area where there is discordance between the clinical finding and the genomic finding, that is clinical low and genomic high, or clinical high and genomic low. For clinical low risk patients, MammaPrint don't have any recommendation regarding chemotherapy. But for clinical high risk patients, chemotherapy could be avoided, but with a cost of risk of distant metastasis at 5 years, that is 1.5% higher. So you have to explain your patients that in case of clinical high and genomic low result of MammaPrint, chemotherapy can be avoided, but there will be a high risk of distant metastasis by 1.5%. The other genomic signatures, like second generation genomic signatures, are 12 gene endopredict, 50 gene prosigna, and breast cancer index, and these are mostly used for deciding endocrine therapy and the duration of endocrine therapy. That will be dealt by our next speaker. So coming to the St. Gallen recommendation regarding the adjuvant systemic therapy in HER2 positive breast cancer and TNBC. So for stage 1 patients, it recommends chemotherapy and trastuzumab for HER2 positive cases, and only chemotherapy in TNBC patients. In TNBC, mostly preferred is sequential anthracycline taxane, that is AC followed by T, or taxane plus cyclophosphamide, that is docetaxel and cyclophosphamide. And but in T1A patient, the recommendation of adjuvant systemic therapy should be individualized. Now, in stage 2 and 3, St. Gallen prefers neoadjuvant therapy, and also neratinib can be used in adjuvant setting in HER2 positive patients where HER2 positive, ER positive tumors who didn't receive pertuzumab. And based upon the outcome of Catherine trial, the trastuzumab emtansine can be used in adjuvant setting if there is residual invasive cancer after neoadjuvant systemic therapy. And based upon CreateX trial, the capacitabine can be used in adjuvant setting in TNBC if there is residual disease after neoadjuvant systemic therapy. So after completion of adjuvant chemotherapy and adjuvant HER2 new targeted therapy, a little bit about adjuvant bisphosphonate in breast cancer. So based upon the EBCTCG meta-analysis published in 2015, ASCO came out with this guideline that adjuvant bisphosphonate was found to reduce bone recurrence and improve survival in postmenopausal patients with non-metastatic breast cancer. Here, the preferred regimens are zoledronic acid, 4 milligram IV every 6 monthly for maximum of 5 years, that is 3 to 5 years, and or clodronate, 1.6 gram daily orally for 2 to 3 years, maximum 3 years. Calcium and vitamin D supplementation should be given unless contraindicated, though clodronate and calcium should not be given concurrently. There must be a 2 hours gap between these two drugs. We must keep in mind about the risk factors for osteonecrosis of jaw and renal impairment, and this should be assessed prior to starting therapy. Regarding data of adjuvant denosumab, it looks promising from ABCSG 18 trial, but currently the evidence is insufficient to make any recommendation for regular use of denosumab in adjuvant setting. So this is all about adjuvant systemic therapy in breast cancer. Now we are going to discuss neoadjuvant therapy, which is a distinct platform for personalized care where systemic therapy is administered before surgery to obtain certain advantages. What are the advantages? It increases surgical options. It renders locally advanced breast cancer to an operable one. It gives the opportunity of BCS for those patients who are otherwise a candidate of mastectomy. and it also offers option of less aggressive axillary nodal treatment like sentinel lymph node biopsy in clinical node positive patients if they were converted to node negative after neoadjuvant therapy. And neoadjuvant therapy is not lesser than adjuvant systemic therapy. They afford the similar survival outcomes. Therefore, we can offer the entire systemic therapy beforehand in neoadjuvant setting and not as a divided manner. That is some part in neoadjuvant and some part in adjuvant. And neoadjuvant therapy is also allows treatment modification based on response. Like in TNBC patient, if you are offering AC followed by T and the patient is not showing any clinical improvement, then you can change it over to platinum containing regimen. And this also allows for in vivo evaluation of treatment sensitivity. So if a patient, a tumor is not responding to chemotherapy and trastuzumab, then likely it is not going to respond in trastuzumab in adjuvant setting also. But neoadjuvant therapy is also not devoid of its disadvantages. Like there is always possibility of over or under treatment if clinical staging is over or underestimated. And there is also possibility of disease progression during neoadjuvant therapy as there is already some subclinical micrometastasis and patient may not respond to neoadjuvant therapy. So who are the ideal candidates of neoadjuvant therapy? In patients with inoperable breast cancer, it is inflammatory breast cancer, then bulky or matted clinical N2 axillary node, and in all patients if it is a clinical T4 disease or clinical N3 disease. In operable breast cancer also, if it is HER2 positive or TNBC and the T size is more than equal to 2 or N stage is more than equal to 1, if large tumor-based ratio is a hindrance for BCS, and if clinical node positive disease is likely to become clinical node negative, where we can offer less aggressive axillary management like uh, uh, SNB, sentinel lymph node biopsy. So coming to the prognostication of neoadjuvant therapy, and the most prognostic indicator here is the pathological complete response. It has been found that those patients having pathological complete response with neoadjuvant therapy had a better survival compared to those having residual disease, and this effect is consistent in all molecular subtypes. So neoadjuvant therapy in HER2 positive disease is already a successful strategy. In TNBC is opening newer pathways, and in luminal B is reshaping the model from neoadjuvant chemotherapy to neoadjuvant hormonal therapy. So in HER2 positive disease, early neoadjuvant trials reported some substantial impact on PCR rate, both with escalation strategies and de-escalation strategies. In escalation strategies, they added trastuzumab in MDSCC trial and NOAA trial, and also they tried dual blockade with trastuzumab and lapatinib and trastuzumab with pertuzumab. In de-escalation strategy, to avoid the toxicities, they avoided anthracycline in TRAIN-2 trial, avoided chemotherapy, Neosphere and Christine trial, and also tried short duration of trastuzumab in Persephone trial, FAIR trial, SHORT-HER, and SOL trial. In TNBC, the most preferred neoadjuvant therapy is sequential anthracycline followed by taxane. However, the PCR rate is consistently low, around 40%. So several trials tried platinum salts like carboplatin and bevacizumab and found a better PCR rate of almost 50 to 60%. Another strategy to improve PCR in TNBC is to use immune checkpoint inhibitors like durvalumab, then atezolizumab and pembrolizumab, and they found to have a PCR rate of almost 60% to 70%. But these are not yet a standard of care and need more exploration.
Ritanda, sorry to interrupt. Could you please wrap up within 3 to 4 minutes?
Sure. Thank you. Okay. Neoadjuvant therapy in hormone positive patients. though PCR rate is consistently low in chemotherapy, however, neoadjuvant hormonal therapy has been traditionally limited to elderly patients who are medically unfit for chemotherapy. However, this system analysis have found that neoadjuvant hormonal therapy is equally efficacious with as neoadjuvant cytotoxic therapy as a valuable option for BCS. However, PCR is less prognostic for hormone receptor positive patients. Therefore, we should ask for newer predictive biomarkers like Ki67 or PAPE index. And neoadjuvant therapy is the ideal backbone for testing newer agents like CDK4/6 inhibitors. Coming to administration and safety of neoadjuvant therapy, very quickly, few important aspects. Anthracycline is a strong vesicant, and you should not allow extravasation. So whenever there is extravasation, please stop infusion, withdraw fluid, elevate extremity, give cold compression, and you may neutralize with dexazoxane. Major toxicities are myelosuppression, nausea, vomiting, alopecia, skin changes, and cardiotoxicity. For taxanes, there is infusion reaction with paclitaxel, and you should use the standard pre-medications. And other toxicities are myelosuppression, neurotoxicity, alopecia, bit of cardiotoxicity, and fluid retention syndrome with docetaxel. Coming to cardiotoxicity of anthracycline and trastuzumab, they are different. Anthracycline causes type 1 toxicity that is mediated by reactive oxygen species, and trastuzumab type 2 by disrupting energy-dependent pathway. Anthracycline-based dose response is cumulative with increasing dose, whereas trastuzumab-based induced cardiotoxicity is non-cumulative and reversible. The maximum dose allowed of doxorubicin is 400 milligram per meter square, and in patients having cardiac comorbidity, and 550 milligram per meter square in other patients. For epirubicin, it is 900 per milligram per meter square. Management of cardiotoxicity, you should identify the patients with cardiac risks. You should use less cardiotoxic regimens. You can use dexaroxane for anthracycline containing regimens, and you can give prophylactic ACE inhibitors, ARB or beta blockers. You should monitor LVF at baseline after anthracycline based chemotherapy and every 3 monthly for trastuzumab. This is a ESMO algorithm for continuation and discontinuation of trastuzumab therapy based on LVF. Coming to the conclusion part, so from all these slides, what we have learned that adjuvant systemic therapy should be offered to majority of early breast cancer and locally advanced breast cancer patients. Selection of therapy should be based upon clinico-pathological factors, molecular profile, genomic signature, comorbidities, and patient's wish. Neoadjuvant therapy should be encouraged in patients who are deemed eligible. Bisphosphonate therapy has very minimal but significant role in adjuvant setting, and we must be very cautious regarding the administration and safety monitoring of systemic agents. I'm very sorry for crossing the time limit, and thank you everybody for your patience here. Thank you.
Okay, so thank you, Dr. Ritam. It was excellently presented and well summarized, starting from the evolution of the systemic chemotherapy to management of toxicities. I was very eager to see some of the questions, but unfortunately, I cannot see any questions in the chat box. So without wasting much of time, I would invite Dr. Abhishek Basu, a very important teacher in our field of radiotherapy and clinical oncology. He is assistant professor of Bardhaman Medical College. So Dr. Abhishek, if you're ready, we can start off with the discussion. Just a couple of thoughts before moving on to with Dr. Abhishek. One or two points I would like to ponder for the junior residents, since it's a module for the junior residents. So whenever you are going to study for this kind of trials and all the regimes, should be very specific about your categorization of what you are going to do. One is a theoretical aspect and another is the practical aspect. So all the slides have been summarized in Dr. Ritam's talk. So having said so, we can move on to Dr. Abhishek's talk on endocrine therapy on the adjuvant and the advanced breast cancer.
Thank you for those kind words of
Abhishek,
introduction.
just
Yes,
just
yes.
1 minute. Ritam, please stay with us. If you have any question at the end, we will ask you. Okay, at the question answer session. Thank you, Abhishek. Please proceed.
So, Ritom, can you please unshare your screen? So at the outset, I would like to thank AROI West Bengal chapter for giving me this opportunity. And it has been a dream for us for a very long time to have this clinical oncology module, which is specifically designed for the junior residents. And the aim of this module is to give you uh, basically important messages that are required, A, for your exam, and B, also for the consideration of what is practically important in dealing with patients as you move along as residents. Ritam, could you please unshare your screen so that I can share it? Thank you so much. So just give me a moment. I think my screen is visible and my audio feed is okay.
Yeah.
Okay, thank you so much. So without wasting any time, I'll proceed with my presentation. So over the next 30 minutes, what I'm trying to give you is a scope of endocrine therapy in breast cancer. And as we know that breast cancer is essentially like many other malignancies, specifically like prostate cancer, largely driven by hormones, and that is the physiology of breast. And we know that the hypothalamic pituitary ovarian axis plays a very, very important role in the evolution and the sustenance of breast cancer, and especially for the hormone receptor positive disease. And over these next 30 minutes, we will actually look at how this is so important for us. So what I am going to cover in the next half an hour is basically this: an overview of endocrine therapy in breast cancer. So the first important question: why is endocrine therapy required in breast cancer? The second question: who are the candidates for endocrine therapy? Is it required for everyone? Third, can we better predict who will benefit most from endocrine therapy? And this has been in passing mentioned by Ritom, but we would nevertheless look at this again. What is the current evidence regarding adjuvant endocrine therapy in breast cancer? And by adjuvant, we mean after surgery. Bone health with bisphosphonates. Again, Ritom has mentioned this, but I have a slide just to show you, and we'll discuss why this is important. Neoadjuvant endocrine therapy in locally advanced breast cancer, and this is something that is a bit debatable, but nevertheless, you should just know that this is one of the possibilities. And lastly, endocrine therapy in advanced breast cancer. Again, as you will see, probably there will be some overlap with the next presentation that Dr. Kaushik Chatterjee is going to make in advanced breast cancer, but I think that is important to harp on important concepts time and again. So the first question: why is endocrine therapy required in breast cancer? And no guesses, this is the estrogen receptor that is shown here, and this was discovered in the year 1958. And since then, I think it would not be an overstatement to say that this has remained the most important prognostic and predictive factor for the treatment of breast cancer. So let us just have a look at the evolution of endocrine therapy. Firstly, what happened was a surgeon, George Beatson, actually resulted in the removal of ovaries and found that there was regression of breast cancer. That was way back in 1896. In the 1930s, tilbestrol was the first drug that was used. Then adrenalectomy from Huggins, androgenic steroids in 1950s, and people were simply roaming about trying different things in apparent darkness because they didn't still have a target. And remember, I told you it was in the 1958 that the estrogen receptor was actually diagnosed. So what happened was a major breakthrough was with tamoxifen, which was discovered and put to use in the 1970s. After that, the major breakthrough that came again was the discovery of aromatase inhibitors in the 1990s. And since then, there has been a plethora of newer agents, including fulvestrant, everolimus, CDK4/6 inhibitors, and PIK3CA inhibitors. So this again shows the picture of the famous British surgeon, Professor George W. Beatson, who actually published a seminal paper on the treatment of inoperable cases of carcinoma of the mamma, suggestions for a new treatment with illustrative cases. And this was actually the removal of the ovaries, which caused a spontaneous regression of certain breast cancers. Remember, this is very interesting because this was about the time that William Halsted was actually going about his seminal publications and series with radical mastectomy. So the concepts were evolving at the very same time. And if you, I hope you would not fail to take the connection that this was also precisely the time at which radioactivity was first discovered. So this is a very interesting historical anecdote. The gentleman and the lady that you see here are Arthur Walpole and Dora Richardson. These two were actually working in the Imperial Clinical Industries of London, and they were toying with a suitable contraceptive pill. Now, what happened was after using many things, and you can see this number actually tells you the number of molecules that they actually researched to come up with this. They came up with a molecule which initially appeared to be an oral contraceptive, but was soon found that it was a failure. But it was something that happened to modulate the hormone responses in women. And this molecule, in fact, was tamoxifen. So what happened was, initially, although it was a failure, it came out to be a resounding success in breast cancer, much like thalidomide, which was a disaster initially, but became the cornerstone of treatment of multiple myeloma. Now, this is a cartoon which shows you the landscape of breast cancer. And you can see here what happens is the estrogen, because it is fat soluble, it goes within the cell and it attaches to the ER receptor, which has two subparts, alpha and beta, but never mind, these details are not important. The estrogen receptor then translocates directly to the DNA where there are estrogen response elements. It attaches to that, and ultimately this leads to transcription and translation and different proteins which go about and give certain signals to the cell to proliferate, especially in the hormone receptor positive breast cells. Bear in mind these pathways because we will have a talk later about the PIK3CA AKT-mTOR pathway, as well as the cyclin D CDK4/6 pathway, which has a role in the regulation of the cell cycle. And you can see here the major drugs that were used in the earlier days, the aromatase inhibitors, which actually prevents the peripheral conversion of the enzyme aromatase and acts outside the cell, whereas the selective estrogen receptor modulators called SERMs, which have a differential activity on some cells, they are pro-estrogenic, and on other cells, they are anti-estrogenic, and tamoxifen is actually a part of this. Now, the hormone therapy in breast cancer has certain determining factors, and other than ER, there is the progesterone receptor, there is the HER2/neu as well, and it would be interesting to know that HER2/neu actually has a role in estrogen positive breast cancer because it is one of the escape mechanisms. So what happens is if the patient is HER2/neu upregulated along with estrogen receptor positive, the HER2/neu could actually impact the estrogen receptor, and this impact is larger in premenopausal women. Also important is the menstrual status. This is not so much in terms of the prognosis as such, although there is some evidence to show that premenopausal women have more aggressive disease, but it is definitely a cause for the choice of hormone. And as you can see here, there are other newer emerging factors here, including the Ki67 and the PIK3CA mutations. The important point that we would like to know before we move along is the definition of menopause. And there are various guidelines regarding this, that some of these come from NCCN, which you already know about, and the European Society of Mastology, which is the EUSOMA guidelines. The basic idea is pretty similar. If the patient is over 60 years of age or has had amenorrhea for a period of more than 1 year, you can consider the patient to be menopausal. But remember, the other, of course, situation would be where the patient has actually had removal of her ovaries. But the most tricky situation is when the patient is actually under treatment and has had a menopause, and this is mainly caused by chemotherapy. So in these cases, you need to be very cautious before denouncing the patient as menopausal. And do we have any guidelines for these patients? Of course we do. In this, the standard guideline, and this again comes from the EUSOMA group, is that you go for serial checking of the serum estradiol and FSH. Estradiol is E2 and FSH. So what would happen in the postmenopausal female? There would be E2 would gradually decrease and FSH would increase, as is apparent from your knowledge of physiology. And this is important. Single finding is not confirmatory, so preferably 2 to 3 serial recordings, each taken at least a month apart, needs to be done or documented before you denounce the patient as postmenopausal. The next important question is, who are the candidates for hormone therapy in breast cancer? And these include the patients who have lobular carcinoma in situ and ductal carcinoma in situ, of course, those who are ER positive, all patients of invasive cancer who are ER positive. It must be borne in mind that a subset of these patients may be candidates for ET alone, but just wait a bit, we'll come to this in a moment again. The important issue that I think needs to be discussed is about patients who are ER unknown. Now, it would sound a little bit heretical discussing this in 2021, but those of us who are working in peripheral centers would know that there is a significant amount of patients who, either because a true cut biopsy could not be done due to some logistic reasons, or because of the improper tissue processing, would always not have their ERPR receptors done. Please bear in mind that it is mandatory for all patients to have a true cut biopsy before treatment is initiated. But in case you do not have that information, there was a notion that tamoxifen could be given blankly, and this was driven from earlier data that was there. But standing in 2021, almost all the guidelines clearly tell you that this should not be done. So if the patient is actually a ER unknown, the benefit of giving tamoxifen is uncertain, and because tamoxifen has toxicities which might potentially outweigh the benefit, it is better not to go ahead with giving tamoxifen as a blanket in these patients. So better don't give endocrine therapy at all. The ASCO CAP guidelines are also important in this context because you need to know what is ER positive. And when we were students, there were hormonal guidelines that were given in femtomoles and picograms. But now it is very, very clear. It's basically a percentage of the cells which stain positive on a standard IHC, and the threshold is 1%. This again has changed. Previously, a decade earlier, it used to be more than 10%. This is now 1%. And the important issue is this is a quantitative measure, but along with this, you also have something which is a qualitative measure. And this qualitative measure is what we call the Allred scoring. So this is a combination of the proportion of cells which actually stain by fraction, as you can see here, and the intensity of the cells, the intensity of the staining. So you simply add these up and you get a score which ranges from 0 to 8. Now, why is this important? It is important to categorize patients who are ER/PR positive. So, for example, two patients, one ER positive with an Allred score of 3 and the other with ER positive with an Allred score of 8, would actually behave very differently in terms of their responsiveness to endocrine therapy. And the higher the Allred score, the better the patient would respond to endocrine therapy. This is by far routine now in all the reports of IHC4, and this is important for residents to know as we move forward. The next important question, which has, I think, been answered first by Anupam in the last class and touched upon by Ritom again in this class, is whether breast cancer is one disease. And I think if we have a resounding answer that all the residents would know by now, it is not. The first instance of this came from this seminal paper by Charles Peru, which was published in 2000, which actually stratified breast cancer into different intrinsic biologic subtypes. And just to tell you this, and this I think Ritom has already showed, so I'll not go into details of this. There are different subtypes, including the luminal, which is subcategorized into luminal A, luminal B, which is again subcategorized into the true luminal B and the luminal HER2, the HER2 overexpressed, and the TNBC. And the reason why this is important is because this has important bearings on treatment. Now, because this has already been discussed several times, I'll skip this slide, but just tell you a couple of important things. Ki67, which is a proliferation index of the rate of proliferation of breast cancer, is also important, and the typical threshold is either 14% or 20%. So higher than that would mean higher proliferation, and this would have a direct bearing on whether chemotherapy needs to be added, as you can see from this slide. The other important thing which I find is a problem among some of the residents is that there is a notion of calling patients who are ER positive and HER2 positive as triple positive. Now, please bear in mind there is nothing called triple positive. The correct terminology for these patients would actually be a luminal HER2. So this is important. There is something called triple negative, but certainly not triple positive. The next important question that we are going to address is how to predict who will actually benefit more from endocrine therapy. And again, because Ritom has touched upon it, I'll be very quick through this. So there are various signatures, and these signatures basically look at an array of genes, and they look at how these genes add up in terms of their gene expression profiles. So those profiles are actually numerically marked, and they give a recurrence score. So you don't have to go into the details, but you would just like to know that you get a score, and the higher the score, the higher likelihood is there that you would actually require chemotherapy. So this is the first evidence that came from the oncotype DX gene signature in the trial, which is known as TAILORx, which Richam talked about. And the bottom line is that this assay said that in up to 85% of early breast cancer patients, and this was in node negative, as Ritam already told you, they can be spared chemotherapy, especially if they are older than 50 and have a recurrence score which is less than 25. And in women who are younger, if they have a recurrence score which is less than equal to 15. The other gene signature is the 70 gene called the BAMA print, and this was again trialed in a more complexly designed trial called the MINDACT.
যে ক্লাসটা
And
ভালো ছিল কিন্তু মিস
I think some of you are not muted. Please mute yourselves. Okay, so this was the MINDACT trial, which actually looked at the 70 gene signature called MAMA print. And again, the basic bottom line was that if you have a lower score in this, you would actually benefit from endocrine therapy even in node positive disease. So the message is very clear. You can stratify patients, and if patients in early breast cancer have a lower recurrence score, they are biologically likely to benefit from endocrine therapy. There are, of course, other different signatures, the names of which you might just know, but this is not important for your exams. These include the EndoPredict, the EpiClean, the PAM50, etc. These are second generation signatures, as Ritam already pointed out. Now coming to adjuvant endocrine therapy in early breast cancer, and this is in ER positive patients after surgery. So we would be looking at what is the evidence, and this is very important as a graph because we'll be looking at this various times. This actually looks at the recurrence rate of breast cancer versus time, and you can see there are two different lines, one for node positive and the other for node negative. And if you look carefully, you would find that the peak recurrence, which is known as early recurrence, occurs within 18 to 30 months after diagnosis of breast cancer. And this is typically the time that is important for us. And we would see why this is important. And see here, the higher peak occurs in node positive as compared to the node negative patients. There is, of course, another peak, and this is important in terms of ER positive patients, which occurs about 7 to 9 years and possibly beyond. And there is a biological rationale why this is important to us. It is also important, as Ritam talked about, that endocrine therapy is generally not to be given along with chemotherapy and only concurrently with radiotherapy. Bear in mind, it can also be used along with HER2-directed therapy like trastuzumab in the adjuvant setting. Now, this is the most important meta-analysis of chemotherapy versus hormonal therapy in early breast cancer in terms of survival. And you can see that this is the addition of hormonal therapy to patients who already received chemotherapy in the early breast cancer. And this comes from the EVCTCG group in 2005. And clearly, there is a benefit in terms of recurrence as well as mortality. The message here is that the difference actually increases as the number of years go by. So once you have started giving the hormonal therapy here, you would actually see that the two curves continue to separate as we move along. So the message here is that not only is endocrine therapy important over and above chemotherapy in patients who are ER positive, the quantum of benefit actually increases as we move along. So this has important bearings in the decision making of what we are going to do. And you can see here that it appears that the quantum of benefit is again more for patients who are node positive. And this is also something that we would keep in mind as we go along discussing about adjuvant therapy. Now, just briefly to discuss the drugs that we have at our disposal. The first drug is tamoxifen, which we already discussed is a SERM, and it is a prodrug which gets converted in the liver to its active metabolite called endoxifen by the enzyme called CYP2D6. This is important. If somebody has a question, we'll discuss this. The most common side effect is hot flushes, which almost everybody has. So it is important that you tell the patients about this. And the most dreaded side effect is thromboembolic events, which you need to be careful about. It is also important that in about 2 to 3% patients, there is a risk of endometrial hyperplasia and possibly uterine malignancies. So the standard recommendation is to go ahead with doing an annual transvaginal sonography for patients who receive this. The aromatase inhibitors are stratified into first, second, and third generation, but we are not interested about the first two generations. So the three drugs that are important in the third generation include Arimidex, which is the drug with the most mature data available in terms of endocrine therapy, which has a long carryover effect, which I'll just talk about. The meaning of carryover effect is that, again, as I showed in the previous graph, once you give the drug and perhaps stop the drug at 5 years, even without the drug, beyond that time, you would have a sustenance of the effect that you see, which I just showed you in the previous graphs. The problem, however, with all aromatase inhibitors and most with Arimidex is that there is an issue with bone mineral density, and therefore you require something to offset that. Coming to the next drug, which is letrozole or Femara, this has the maximum suppression of estradiol, is very similar to Arimidex, and remember, these two are non-steroidal aromatase inhibitors. The specific advantage from evidence is that it appears that this drug has a little bit of advantage in node positive in terms of overall survival. Again, the problem with this drug is that it has cardiovascular side effects. If the patient has major cardiac comorbidities, you would be careful in choosing this drug, and has less problem potentially with bone mineral density. The third drug is exemestane, and this drug is again a steroidal aromatase inhibitors, which is different from anastrozole and letrozole. And this, because of the steroidal nature, has least problems with bone mineral density, and for women who have osteoporosis could be a better option than the non-steroidal AIs. Coming to the adjuvant endocrine therapy in early breast cancer, the evidence that we have. Now, this is again important. For premenopausal women, the drug of choice is tamoxifen. And the simple reason for this is, if you have loads of estrogen roaming all about, simply looking at targeting the aromatase inhibitor enzyme is not going to have an effect. It is simply like trying to remove a couple of mugs from an ocean, which would not serve any purpose at all. So it's better to actually look at targeting the estrogen receptor, and that is what we do. Now, the important question is, how long should we give tamoxifen? And initially, it was given for a period of 5 years, but now we do have data, especially from the trial called Atlas, which shows that extending the duration of endocrine therapy with tamoxifen from 5 years to 10 years is beneficial for precisely the same reason that I've been talking about, the carryover effect. The next important thing is, should we try to suppress the ovaries in any way? And this can be done by surgery, oophorectomy, radiation, which is the least preferred choice, and certainly by medical means, by GnRH analogs. Now, there are two important trials that actually looked at this, called the SOFT and TEX. Don't go into the details of the trials, but the important issue is that it used a GnRH analog, although it's not the very ideal drug, which is not commonly used, called triptorelin. We commonly use drugs like goserelin out here. But the message, I think, is important, that the combination of an AI, which now can be used because you are using ovarian suppression, is better perhaps than using tamoxifen plus ovarian suppression. So this was one of the early indicators which showed us that an AI could be potentially better than tamoxifen in this setting. And there is actually a very large meta-analysis which has looked at this aspect of ovarian function suppression along with tamoxifen, and found that there is a definite benefit both in terms of disease-free and overall survival in these women, especially in younger women, at the terms of slightly increased toxicities, which is again quite obvious. Coming to the post-menopausal women, and here the choice is pretty obvious, and this has been driven largely from the data of different trials. Of course, for the sake of time, I'll not go into the details of this, but I'll just give you the take-home messages that are important. So what are the strategies? The first strategy is to go with an AI upfront for 5 years. The second strategy is for women who have been started on tamoxifen to go for the AI after 2 to 3 years, which are known as switching. The third strategy is to go for tamoxifen 5 years and then a further AI for 5 years, and this is known as extended adjuvant. And the next strategy, I think, is not very important, so we'll not discuss this. women on adjuvant endocrine therapy for upfront 5 years, and the most important two trials are the ATTACK trial, which was with anastrozole, and the big 198 trial, which was with letrozole. Now you can see this is the area which we were targeting, and what was the result of these trials? The result of the trials, and this is a combined analysis of both of these, was actually pretty simple. And this was that the upfront adjuvant AIs decreases the recurrence and improves the disease-free survival. However, overall survival seemed not to have been largely impacted, and this is important. Now, if you look at data from a large EBCTCG meta-analysis, which also compared this tamoxifen versus AI upfront, again, you look at the same message that I've been talking about. There is a clear separation of the curves, both in terms of recurrence and mortality. And it appears that this quantum of benefit increases as time goes along. So you know that you have actually given the intervention up to here, but you see the curves continuing to separate beyond, and this is the beauty of endocrine therapy in breast cancer all along. Coming to the next set of trials called the switching trials, and you would see that the time of switching is 2 to 3 years, which is typical of the time that we actually discussed before when the early recurrences occur. Now, if you look carefully, the message of all these switching trials was again very similar to the upfront trials, but the quantum of benefit, if we look in absolute terms, was slightly lesser, and this is shown here. So the curves are pretty similar in this, the same meta-analysis, the subset analysis of switching trials, but it shows that possibly the upfront AI for 5 years is the better strategy to look at, especially if we want to target women with ER-positive postmenopausal disease. The next important thing is the extended adjuvant. And the reason why these trials were done was basically for the late recurrence, if you remember in a previous slide I showed. So ER-positive women might have a recurrence again around the 7 to 10-year mark. And therefore, why not target these women in the second 5 years? So extend the total time, just like the Atlas trial did for tamoxifen. And the most important trial in this space is the NA17 trial. Again, do not go into the details of this. This simply gave letrozole for a further period of 5 years beyond tamoxifen. And what was found was that there seemed to be not only a benefit in DFS, but also overall survival, especially in the node positive subset. And based on this, what you had is an ASCO clinical practice update, which came out in 2018. And this clearly stated that extended adjuvant AI therapy was not recommended for low risk women, but was certainly recommended for women who were node positive, and the duration would be for a maximum of 10 years. And there could be toxicities, but it seemed that the benefit outweighed those toxicities, so it is better to be given. Coming to bisphosphonates, I've already talked about that there is a detriment in bone mineral density with the aromatase inhibitors, and therefore you have the bisphosphonates. Again, there are different generations, and the highest number of data is with zoledronic acid at a dose of 4 milligram, which is typically recommended every 6 months intravenously over 30 minutes. And again, this is a very, very large meta-analysis of 18,000 women from the EBCTCG group, which tells you a very fascinating story. So what was supposed to happen with the addition of bisphosphonates? You would have a better bone mineral density, which is detected by a routine DEXA scan. And as Ritom told you, you also require calcium and vitamin D3 supplementation. But the interesting aspect is that in addition to the benefits of bone mineral density, it seemed that there was a benefit in overall survival. Now, nobody can actually tell us why this happened, but this is an important message. And this message was found typically in postmenopausal women. So along with your benefit in bone mineral density to offset that with ER positive postmenopausal patients on AIs, the additional benefit of giving bisphosphonates is that it actually leads to a benefit in overall survival in early breast cancer. And this is, I think, something which you need to remember as residents as you go along. What about denosumab? I've deliberately not put it because the data is conflicting and probably we shouldn't be using it. Just 1 or 2 slides about neoadjuvant endocrine therapy. So what is basically this? In patients who are locally advanced, we know that the typical paradigm is giving chemotherapy. But what about endocrine therapy if the patient is highly ER positive? Is it possible? Yes, it is. But the current data shows that the pathological complete response rates, which is this endpoint in these patients, is not very great. And it takes a lot of time for hormone therapy to act vis-a-vis chemotherapy, which acts faster. So possibly this is reserved only for patients who are not candidates for upfront neoadjuvant chemotherapy. Coming to advanced breast cancer, and this is the last part of my presentation. So the important message is that in spite of endocrine therapy, at least 30% of early breast cancer patients would actually progress to advanced breast cancer. And there you have to actually weigh the benefits of endocrine therapy, which is slightly more in terms of lesser toxicity and better quality of life. And it so appears that all the major guidelines that you see actually recommend endocrine therapy for advanced breast cancer in patients who are ER positive strongly in terms of chemotherapy. And the important message here is to know what is visceral crisis. So visceral crisis basically means that it's not only a metastasis to any viscera. It means that there is an end organ dysfunction. So a patient who has a solitary liver or lung metastasis is not in visceral crisis. If a patient has a hepatic failure or a pulmonary failure because of the overwhelming nature of metastasis in advanced breast cancer, only then is a patient in visceral crisis. And only these patients would become the candidates for chemotherapy. So the message is, even in advanced or metastatic breast cancer, if the patient is endocrine positive, that is ER positive, that patient is still a candidate for upfront endocrine therapy in this advanced stage. Probably the paradigm of endocrine therapy would change. It is also important to note, and I'll skip this slide, about primary and secondary endocrine resistance. I think you would get a video of this, so it's not important to go into the details of the definition, but this is important for patients who have an endocrine resistance upfront versus who have been previously received endocrine therapy and have later gone on to have endocrine resistant, and the strategies could be slightly different for these subset of patients. So I'll come back again to the cartoon that I showed, just to show you what are the additional targets that I'm just going to allude to in a moment. The CDK4/6 inhibitors, which target this part, the mTOR inhibitors, which target out here, and the PIK3CA inhibitors as well. And I'll talk about 3 important drugs as we go along, because these are new kids on the block. So these are the ESMO guidelines for sequencing. Again, don't go into this because you can see the term that I've mentioned here. The sequence of endocrine therapy in advanced breast cancer is uncertain. So basically, I will give you the take-home messages of which drugs are used and what is important in this setting without trying to confuse you much. So the first drug that came into this space was fulvestrant, and many of you have already used it. This is an injection which is used typically in a dose of 500 milligram initially, and then 250 milligram. And this is a little bit of a concern for a patient because you have to come periodically, monthly for injections. And there are issues with injection site reactions and GI disturbances. But this is a drug that is actually a selective estrogen receptor down regulator. So this leads to complete apoptosis of the estrogen receptor. Now, the important message here is that the dose needs to be 500 milligram in this schedule. So day 0, on the first day, it will be 500 milligram. On day 14, again 500 milligram. On day 28, 500 milligram. And thereafter, it has to be monthly. So the beauty of this drug is that it appears to be better than AIs alone in the setting of metastatic breast cancer. However, there are issues if the patient has large amount of visceral disease, because only limited bone metastasis. The other drug which has been used subsequently in the second and third lines of advanced breast cancer is everolimus, which is a pretty toxic drug, an mTOR inhibitor, and it was used along with exemestane in the Bolero trial at a dose of 10 milligram. However, there are significant toxicities for those who have used it. And this is important, as I've just shown. I think I'll not go into the details of this trial, just to show that it has been used with the drug called exemestane in the subsequent settings. And the last set of drugs that I'll talk to you about are the CDK4/6 inhibitors. So the first drug in this setting was palbociclib, and this is used at a dose of 125 milligram given for 3 weeks continuously, and then 1 week gap, and it can be dose de-escalated. The problem of these drugs is there is a lot of neutropenia with some amount of febrile neutropenia. However, this neutropenia does not often require GCSF, as is the case for chemotherapy, because it is self-limiting once the drug has been given. I'm sorry, I'll go back to the previous slide. So this is the trial that actually looked at palbociclib along with letrozole in the first line setting, and it showed a significant benefit, first in terms of progression-free survival, as well as in terms of overall survival. The second drug, which is ribociclib, is also another CDK4/6 inhibitor. Bear in mind the difference in toxicity, where there is less amount of neutropenia, but more amount of QTC prolongation. And this is something that you need to keep in mind when you are using this. So a routine ECG monitoring is required along with liver function monitoring is the group of drugs. And the reason I mention only this trial amongst the various trials for ribociclib is because this has changed the paradigm for advanced premenopausal breast cancer. So this is a case where ribociclib was actually combined with AI or tamoxifen and OFS in premenopausal women. So remember, tamoxifen is the only drug that's recommended in any setting. So this is the first time a CDK4/6 inhibitor has been used, and there has actually been a significant improvement not only in progression-free but overall survival. So this potentially in advanced breast cancer is a new paradigm for women with premenopausal disease. And the last kid on this block is abemaciclib, which is again a CDK4/6 inhibitor and has a problem of protracted diarrhea. And this is only coming into India very recently. So just to make things simple for you, this is a slide that is probably easy for your exams as well. For some of these,
sorry to interrupt. Just 1 to 2 minutes left.
Absolutely, I'll finish within that time. Don't worry. So the thing is that this is a cartoon that shows you the 3 drugs, which is important simply because some of these come as short notes for your examination, and you can just go through how these drugs compare with each other. So the data that is there with in terms of efficacy, CNS penetration, which is more for abemaciclib, neutropenia most for palbociclib, and QTC prolongation for ribociclib. There is, of course, a meta-analysis that has looked at combining all the data for all the trials for CDK4/6 with endocrine therapy. And again, the bottom line is that there appears to be benefit of overall survival. So the clear recommendation is wherever possible in advanced ER-positive breast cancer without visceral disease, you should give a CDK4/6 inhibitor together with endocrine therapy, which is an AI. The last couple of slides of my presentation deal with a new molecule or a new paradigm at all, which is the PIK3CA mutation. Now you remember that this is one of the escape mutations that I showed you in the earlier cartoon in advanced breast cancer. And this is found surprisingly in quite a significant number of patients. Now the problem is that this occurs in 4 isoforms, and the initial drugs that were used for this actually led to a problem because they were significantly toxic. So newer generation PIK3CA drugs are now on the horizon. And just to give you the name, because I think going along when you will be appearing in your exams, this will become a paradigm which is already approved, is a drug called alpelisib, which has been used in patients who have failed CDK4/6 plus endocrine therapy in the first line in advanced breast cancer. And this drug is going to probably herald a new era in the treatment of advanced breast cancer. So quickly coming to the summary of what we have discussed, ER remains the single most important target. There are emerging targets like CDK4/6, of course. The clear definition of menopause, pre versus postmenopausal, is important, as is the IHC4, which should be mandatory with ALRED. Chemotherapy may be safely omitted in a subset of patients with ER-positive node negative disease. Adjuvant endocrine therapy should be given at least for 5 years in early breast cancer, with tamoxifen as a standard of care in premenopausal, where transvaginal sonography is mandated yearly. AI is better than tamoxifen in postmenopausal. Bone health, however, remains a concern, for which bisphosphonates should be used also for the overall survival. Extended endocrine therapy, both for tamoxifen and AIs, should be used, especially in node-positive patients. I have already talked about the bisphosphonates. And neoadjuvant endocrine therapy is an option in selected patients where chemotherapy is not an option. In advanced breast cancer, again, endocrine therapy should be the treatment of choice in patients without visceral crisis. The optimal first-line treatment appears to be an AI with CDK4/6. And even in premenopausal, it should probably be an AI plus GnRH plus CDK4/6. And you have different drugs with different toxicities. In second line, it is typically fulvestrant with CDK4/6 or fulvestrant alone. And the new kid on the block is probably the PIK3CA mutation-driven drugs like alpelisib, which heralds significant promise. So I'm sorry again for overshooting time slightly. Thank you so much for giving me a patient hearing.
All right. Thank you, Dr. Abhishek, for the excellent, elaborate presentation. So we have a couple of questions. I think the first question can be directed to Dr. Rhythm. It is that the question is, should we go for immunohistochemistry testing routinely before starting neoadjuvant chemotherapy? If Dr. Rhythm is there, can you please take on the question?
Yes, sir. Okay, it's a question from Dr. Hamid Chaudhary. Am I clearly audible? Okay.
Yeah.
So ISC4 score came from a team cohort of TransAttack trial. So it was meant for only adjuvant setting, but actually ISC score consisted of ER positive, ER expression, PR expression, HER2/neu expression, and Ki67 expression. So ISC score prognosticates and predicts of pathological complete response in neoadjuvant chemotherapy, and with using the ER, PR, HER2/neu, and Ki67 separately, we'll have almost 16 defined subtypes in combination of all these factors. But ISC4 actually gives a mathematical scoring, keeping in mind of impact of all these individual prognostic factors. Therefore, ISC4 can be used for before neoadjuvant chemotherapy to predict the outcome, that mostly the PCR rate, particularly in luminal subtype, but is still not recommended routinely. So you can use ISC4 before NSCT, but it's still not recommended as a standard of care.
All right. So moving on to the second question, which can be directed to
Sir, please unmute yourself.
So I think I've already seen the question. So
Yeah.
I think it's from Orko Provo. The question states that what is the role of adding tamoxifen in ER negative, PR positive patients? And this is an interesting question. So the first thing that needs to be mentioned is that isolated PR positivity in absence of ER positivity, that is an ER negative and PR positive, is likely artifactual. And I'm quoting a very senior pathologist, Professor Dr. Anita Borges here. This is important because the ER receptor is extremely heat labile. So what happens is that when you are processing the tissue, the chance of the ER receptor getting destroyed is significantly more than the PR receptor. And that is a reason why, and this is, I think, a message that should go to all the residents, many of whom are actually doing a TrueCut biopsy on their own at different centers. I'm aware of that. Is that when you do a TrueCut biopsy and take course, you should immediately fix it in formalin, and you should mention the time of fixation very clearly when you send it to your pathology colleagues. So ideally, it should reach the pathology laboratory within a time of 4 hours. So a proper tissue processing on freshly taken course, which is fixed immediately, is very important, especially if you are looking at ER positive disease. And therefore, this idea that it should be ER negative and PR positive is likely artifactual. Now, coming to this specific question, what should be if this is ideal and still you have a PR positivity? The recommendation from most of the guidelines says that if it is ER and or PR positive, you could go ahead with endocrine therapy. So it's not about tamoxifen, it's also about AIs. But the chance of benefit is significantly lesser if you have only a PR positive rather than a ER positive. On the other hand, PR positivity has a clear role in prognostication with ER positive. So if a patient is ER positive and PR positive, the chance of endocrine responsiveness is much more than if the patient is ER positive only and PR negative. I think Vitom has some comment to make. Okay. So if that answers your question, Orko.
Okay, Orko has already told yes, sir. Okay, it's fine. Abhishek, thank you.
Thank you so much.
Yeah. Dr. Shamrat, sir, are you there?
I think Shamradda, you are muted. Could you please unmute yourself?
Yeah. So am I audible now?
Yeah.
So, before moving on to the last part of today's discussion, So often in the theory part of the examiners, just particularly for the junior residents, we come across two kinds of theory questions. One is like, a definite clinical OSCE type question, which is given. Another is like a blanket type of question, like what is the role of the adjuvant or endocrine treatment in premenopausal ladies having breast cancers. Now, having a question formed like a blanket question like this, like a premenopausal lady having a breast cancer, what is the endocrine treatment? For the junior residents and students, I would like to advise you to frame your answer into 4 different parts. The first is you discuss about the role and rationale and the types of drugs and the dosages. Then in the second part of a discussion, briefly you write about the basics of the major trials, particularly like the Atlas and Atom trials. In the third part of discussion, you don't forget, to write about the ovarian ablation, that is the radiation and the oophorectomies part. And in the fourth part of discussion, I would like to get some of the comments from regarding the resistance and recurrence and the primary hormonal resistance. Having said so, I think there is another term loosely addressed that is perimenopausal. So just for the sake of notifying, there is nothing called perimenopausal. It is either premenopausal or postmenopausal, biochemically or clinically. So we move on to the last part of today's discussion, which is oftenly comes in the 4th theory paper, that is the theory paper 4, the recent advances. So to discuss on this, I would invite Dr. Kaushik Chatterjee, my friend, fellow and colleague, associate professor, posted in IPJMER Kolkata Department of Radiotherapy. He will be talking on the systemic therapy in the advanced metastatic breast cancer, and also highlighting on the recent advances of the CDK4/6 inhibitors, PARP inhibitors, and a part of the immuno-oncology also. So Dr. Kaushik, please proceed.
Thank you so much, Amrita. I'll just try to share my screen from here. Am I audible?
Yeah.
Thank you. I'll share my screen. So is the screen visible now?
Yes, it is visible.
Okay, so
Yes.
should I start? Yeah, so very good evening, all of you. I am literally the last man standing after such extensive discussion on the adjuvant therapy, neoadjuvant therapy, and what a way to sum up the entire kitty of hormone therapy by Dr. Abhishek Basu, my previous speaker. Now, having shared all the data and extensively talking about the clinical trials, they've just left me with the philosophy. That is the reason why I just added one line: systemic treatment of metastatic breast cancer, the philosophy. Because you see, the systemic therapy of metastatic breast cancer, it basically includes from the start to the end of everything. So it's a huge, huge topic. You can only talk about philosophy. So philosophy, by saying that, I really mean there are guiding principles that will tell us how to proceed with each and every step. There are guiding principles that are going to tell us what not to do. So it is very essential that I will not deep dive into individual clinical trials. It is also essential for me to wrap up in 30 minutes. Therefore, let's proceed. So this is my first slide, and why I kept this, because from age-old evolution of this oncological science, from our teachers to us, we have come to understand that stage 4 disease are incurable. They were incurable. But having said that, over the period of last, say, 4 or 5 years, our concepts have changed. We have now come to terms with the fact that even stage 4s can be cured. So do not exactly judge all stage 4s as incurable. Because of this concept of oligometastatic disease, you can see our intent of treating an oligometastatic disease is basically to achieve a cure. And what do we mean by oligometastatic disease? Let's not get into the numbers of 3 or 4 or a single mets here and there. Let's understand what are the 2 main pillars of treating a solid tumor with a curative intent. And the 2 pillars are surgery and radiotherapy. Anybody who's saying that it's a solid tumor and you can only cure the disease with chemotherapy is absolutely wrong. So any metastatic disease which is amenable to these 2 forms, like for example, we have got 2 lung mets which are in the periphery and they are amenable to, so say, SBRT. They are curable. You have a single mets in a spinal bone, we can remove it. It is curable. or say an extremity bone, we can remove it. Or say there are one or two mets in the liver, which can be resected. They are all stage 4 disease, but they fall under the oligometastatic criteria. Therefore, our intention has to be revised. Whenever we face a stage 4 patient or a metastatic breast cancer patient, we have to understand, is it the one in the bottom one, which is a non-oligometastatic disease, where our main intention is prolongation of overall survival, the progression-free survival, getting on the quality of life, and palliation. So today, I'll keep my discussion exclusively to the non-oligometastatic disease, where our intention is not to cure, which is improbable. But having said that, we are now achieving 4 years, 5 years, even 7 years in metastatic breast cancer. And why? It's because the ample amount of treatments we now have in our hands. Let's look at it. So a moment a metastatic breast cancer comes to you, you have to divide your thoughts in 8 parts. And these are these 8 parts. It has to start with assessing the performance status, PS. We have to then understand whether this patient has a progressed from an early stage or a locally advanced stage to metastatic disease, or has the patient directly come to us as a de novo patient, directly diagnosed as a metastatic breast cancer. Number 3, we already had a wonderful talk about visceral crisis. So whether this metastatic breast cancer patient is in a visceral crisis, and I'll come to one slide saying what already Abhishek has already discussed. Point number 4, the very vital 3 points, one after the other. Whether the patient is PR and PR positive, it is going to tell us what to do. Point number 5, whether the patient is HER2 positive or negative. Point number 6, whether the patient falls into that category of triple negative breast cancer, which is a separate chapter altogether. Point number 7, what is the site of metastasis? Do we have anything specific for any specific kind of metastasis? Like, for example, what Abhishek already said, brain penetration, abemaciclib. If you're using a CDK4/6 inhibitor, you can choose. Like, for example, bone-only mets, you can choose fulvestrant, where it stands out from the other group of the hormone therapies. So your site is also important. And at the last, the special mutations. And I'm sorry, Dr. Shamrat Dutta, he wanted me to touch upon even the immunotherapy, the most depths of targeted therapy. But believe it, I will not be able to wrap it up in 30 minutes. I just wanted to talk about principles, and the principles are these drop downs, starting with PS, de novo or progressed, whether in visceral crisis, ER and PR status, HER2 status, whether patient is TNBC, we can find out that from the above 2 parameters, cytometastasis, and presence or absence of special mutations. Now, having said that, I need to move on to the next slide, which says why PS is very important. Students, it is purely for the students. The teachers are not listening to this. Mug up your ECOG performance status. It is 5 lines, and the 5 is death, and 0 is the patient doesn't have any symptoms, yet the patient has a disease. So ask one single question. Is the lady bed bound for more than 50% times? The answer is yes. It means your ECOG performance status is 3. You don't need to mug anything else. Just one single question can tell you whether the performance status is 3 or more. And if you have an answer as yes, the lady is more than 50% time bed bound, forget chemotherapy. But having said that, you can only forget chemotherapy. At this PS, you can still go ahead with your hormones. You can still go ahead with your HER2-directed therapy. But having said that, you're giving hormones, but if you're combining it with everolimus, which Abhishek has already discussed through the Bolero group of trials, if you're combining it with everolimus, your PS comes in at PS3. You do not give the Bolero or the Tamrad group of drugs where you combine a hormone with everolimus. And also, having said that, ECOG PS3, Dr. Chatterjee is asking you to give the patient anti-HER2 therapy, but you have to check the echocardiography, the ejection fractions, before deciding on the HER2 therapy. So, as I have said, ECOG PS3 rules out chemo, but it doesn't rule out the hormones or your anti-HER2 therapies, that is the HER2-directed therapies. Having said that, do not directly assess PS just like that. Correct the correctable ones before judging the PS. If the patient is in extensive bone pain, you know the patient is bedbound because of the bone pain. You can do jolly well put the patient on something that produces the bone pain. Pleural or pericardial effusions that can be drained. It is going to improve the PS. Obstructive jaundice because of a node can be dealt with a pipe, or an obstructive uropathy can be dealt with say a stenting of the ureter. So these are correctable options, and whenever you have something that is correctable to improve the PS, do that and then judge the performance status. The next part will be another vital thing, visceral crisis. We already had the definition. It is a clinical as well as a biological parameter based condition where either disease is rapidly progressing or we have an impending fatality of a specific organ. But once again, do not judge visceral crisis just like that. Look at the correctable situations as you may. Like in the similar lines, you might misjudge the performance status. You can also misjudge visceral crisis. You can see if the patient is having, say, 3-4 lung mets, and the patient is having so much shortness of breath that you cannot explain it with those 3 lung mets. Then look for pleural effusion, look for pericardial effusion, see if they can be drained. Similar lines, look for obstructive jaundice, look for obstructive uropathy. This will improve the patient's visceral crisis. Okay, so these are 2 very important parts. Then finally, I'll come to how do you now divide your patients. You have looked at the performance status, you have looked at whether the patient is in visceral crisis or not. Now comes what is the correct division of the uh, disease burden. Like for example, on your left top, you'll find, as already Abhishek had said, that 30% patients roughly are going to progress from the early or the locally advanced stage to the metastatic stage. But having said that, only 4 to 9% of the women will come de novo, but this is not a data from India. Our at least 25% patients can come as de novo metastatic disease. Now, what do? Look at the molecular profile and divide the patients, whether they're hormone receptor positive, whether they're HER2 positive, or whether they're totally triple negative. The total triple negative group will be 50% in your 15% in your practice. Now, the most common, that is 60 to 61%, will be the hormone receptor positive and the HER2 negative group. This is roughly around 60%. And the least common, or the lesser common than that, will be hormone receptor positive and HER2 positive, which is the luminal HER2 group. It is not triple positive, as Dr. Abhishek Basu has already highlighted. So that group will be 15%, and the most common group would be hormone receptor positive, HER2 negative. This, keeping in background, will slowly move on to our main thoughts. Like this one. Yes, chemotherapy is there, but who are those patients who will be opting for chemotherapy, and you will have to think for chemotherapy? Look at this. As I already said, ECOG PS3 onwards rules out chemo. So ECOG PS up to 2, think chemotherapy. Now, if the patient is in visceral crisis, which have already been discussed, irrespective of your molecular profile, forget the rest, think about chemotherapy. If the patient is already triple negative, you know ER and PR is negative and HER2 is negative, you don't have an option, you have to give for chemotherapy. So for a TNBC, chemotherapy. For ER and PR negative disease, irrespective of visceral crisis, you don't have a chance of giving hormone therapy out there, you have to give chemotherapy. ER and PR positive disease, and you have finished off all your lines of hormone therapies, one after the other in sequence. What do then? You have to end up using chemotherapy. Then you can take a call whether the patient is de novo or is a progressed metastatic breast cancer. If the patient is de novo, then you already know what are the lines of chemos that have been given. If the patient is de novo, then the patient is upfront, and you can deal the patient like you deal with the first case. Like you can start up with your anthracyclines, followed up with the taxanes, the usual ones. You do not have to think about what are the previous lines of treatment. For a patient who has progressed from the early or locally advanced stage, they are the ones who will need a thought regarding what were the therapies that were given, and you have to look at that what sequentially the other lines of therapy could be used. So that's the way. Now let's look at whether we can add HER2 directed therapy. Is my background noise too high?
Not really.
Thank you. I think there is a fight going on outside the hospital. Okay, so what do? Add HER2 directed therapies for the HER2 positive disease and bone directed therapies for the skeletal mets. So this is in combination with your chemotherapy that you are using. Do not combine hormones with chemo. Mind it, students, you have to understand that the chemotherapies that we are using, they are all cytotoxics, and they are cell cycle specific. It means your anthracyclines will be specifically active in this ACE phase. Your taxanes will be specifically active in the M phase. Now, if you're using a hormone along with it, which is cytostatic, it's going to halt the cell cycle or halt the cells from going in through the cell cycles to the sensitive phase. So basically, you cannot add up hormones with your chemotherapy part. Everything else can be added up with your chemotherapy. So you can add up chemotherapy with radiotherapy, chemotherapy with trastuzumab, that is anti-HER2 therapy. You can add up chemotherapy with the other things as well, like immunotherapy, but not chemo and hormones. So remember the cumulative doses as well. If the patient has previously received anthracyclines and you want to receive anthracyclines, give anthracyclines as well, then you have to remember the upper limits. I think
With the cytostatic. Do not combine hormones. Hormones cytostatic remain the cell cycle specificity of the constant chemo.
Please everyone mute yourself. Yeah.
So are they muted? Yeah. So, which Rhythm had already said, remember the upper limits. I learned the upper limit as 450 and 550 for the left and right. So, the range of upper limit of anthracyclines, that is doxorubicin, would be between 400 to 450 milligram meter square, and 550 with or without radiotherapy, divided between the left and the right. So these are the chemotherapy parameters that you have to understand. And the chemotherapies are the simple ones that you use every day. It is anthracyclines followed by taxanes or a combinations of them. But what you have to remember that in the metastatic setting, the preference is single agent used in sequence, one or the other. Having said that, if you have started chemotherapy for a visceral crisis and you have done 1, 2, 3, 4 cycles, if the visceral crisis has crossed, stop chemo. If the patient is ER and PR positive, go ahead with the hormones because the patient is no longer in visceral crisis. And also add on to your anti-HER2 directed therapy if the patient is HER2 positive as well. So if you're using chemo to bypass the situation of, say, visceral crisis, once it is done away with, you may not continue with your chemotherapy because of the toxicities. You can shift the patient over to the hormones and the HER2 directed therapy. So this was roughly about chemotherapy. Next one is, what do you do if the patient is ER and or PR positive? The first line, check the first line. There is no visceral crisis, ER and PR is positive, and the situation is, you decide and think about what if the ER and PR is positive and HER2 negative, the most common group. Remember, 60 to 61% patients will be in this group. They will be hormone receptor positive and HER2 negative. So what will be their first line? Think in the postmenopausal setting. See, 1, 2, 3, 4, all of them can be first line. Any of the above can be first line. It is not a sequence I'm talking of. It is NSAI, that is non-steroidal aromatase inhibitors. That is your anastrozole or your letrozole. Or you can use NSAI plus CDK4/6 inhibitors, as already discussed in details by Abhishek. So what if you are using a CDK4/6 inhibitor? What is your choice of NSAI? The choice of NSAI is letrozole because all of the trials have used letrozole as a partner. Some, though, there is also data with anastrozole, but it is mostly letrozole with a CDK4/6 inhibitor. And we had this fantastic presentation from Abhishek about which CDK4/6 inhibitors to choose. You can see QT prolongation. It's wrong. It favors palbociclib over ribociclib. Correct the first line. Favors, I have written favors ribociclib over palbo. If QT prolongation is there, then it will favor palbociclib. Dose denominations. What is dose denominations? It means, suppose because of repeated neutropenia or an event of febrile neutropenia, you want to decrease the dose of palbociclib. Then palbociclib, the whole set has to be removed. They come in 125 milligram and separately they come in 100 milligram. So if you're reducing by a factor of 25 milligram, then you have to buy a new set of the drugs, which is not a problem with ribociclib. Ribociclib comes in a 200 milligram and you have to take 3 tablets or 3 capsules. So that makes up 600 milligram. If you want to reduce the dose, you can just take 2 tablets instead of 3. So dose denominations, it favors ribociclib. Now, having said that, ribociclib also is not fussy about food. And brain metastasis, you have to look at that chart. Anything, the highest amount of brain penetration with abemaciclib, and before choosing abemaciclib, you also have to remember the diarrhea is a big concern. So this is how you keep on choosing. QT prolongation favors palbociclib, dose denomination, it favors ribociclib, Bren-Mets favors abemaciclib. But having said that, palbociclib is the number one to come, and most of our experiences and the bulk or volume of the initial data had come from palbociclib. So it's up to you to choose looking at these parameters. Now, fulvestrant, as I said, is the preferred option if bone-only metastasis is there. And tamoxifen, as my friend Abhishek has already said, if NSAI is somehow contraindicated because of your bone mineral densities, you can still think of using tamoxifen in this setting. But remember, for premenopausal, medical or surgical oophorectomy plus the above sequence is the way to go. Next one is, what about if there is no visceral crisis, ER and PR is positive and HER2 is negative? What do you do in the second line? Simple. We have used NSAI that is non-steroidal. We'll think about using a steroidal one, that is exemestane. We can add fulvestrant if tamoxifen or anastrozole letrozole has been used in the first line, pardon me. We can add a fulvestrant with CDK4/6 inhibitors. It means we can have still have an option of repeating our CDK4/6 inhibitor counterpart along with the second line. That is, after in SAI, we can use fulvestrant along with CDK4/6 inhibitors. We can use fulvestrant plus alpelisib. This is a new drug if we have PIK3CA mutated. We can use a steroidal inhibitor, that is aromatase inhibitor, exemestane, in combination with everolimus via the Bolero trials. So these are all your second-line options. And believe it, if along with this your HER2 is positive, then we can add on HER2-directed therapies for a HER2-positive disease. But having said that, you have to remember, in a slow-growing or indolent disease, the combination of hormones along with anti-HER2 therapy had actually not produced a better overall survival. Carrying on with the single hormone is also good enough in that case. And of course, you have to remember what are the criteria for chemotherapy. When you have used up all your sequences of hormones, you shift to chemotherapy. So this is the ER and PR positivity. Now let's look at the HER2 new positive group. Now add HER2 directed therapy whenever the HER2 is positive. But students, be careful about the ejection fraction on echocardiography. You have to have an echocardiography upfront before you start therapy with trastuzumab. And of course, you have to remember that even taxanes and anthracyclines cannot be forgotten. They add up to your cardiotoxicities. Ritom had jolly well discussed in details regarding the cardiotoxicity profile of all the three groups, anthracyclines, taxanes, and that caused by trastuzumab. So remember, whenever the patient is on anti-HER2 therapy, it's a echocardiography done preferably after every 3 cycles. So what are our drop-down options? We can use trastuzumab if not used in the first line. We can use the trastuzumab, pertuzumab, taxanes combination if not used in the first line. We can use lapatinib as a single agent. We can use lapatinib plus capecitabine. We can use lapatinib plus trastuzumab. And at the end, we can also use TDM1. Mind you, TDM1, that is Kadcyla. It can be used after the use of trastuzumab plus minus pertuzumab, or instead of a LAPCAP, it can compete with LAPCAP because the TDM1 study is against lapatinib and capecitabine combination. In my next slide, I'll just give you a brief on the second line anti-HER2 directed therapy. You can see Cleopatra brought out the trastuzumab, pertuzumab, and docetaxel over trastuzumab and docetaxel. Now, the Emilia had compared TDM1, that is Kadcyla, against capecitabine and lapatinib. We had Teresa that compared TDM1 versus treatment of physician's choice. And we have combination of trastuzumab and lapatinib versus lapatinib alone. So these are our HER2-directed therapies in the later lines. Now, what about TNBC? It has been dealt with in details. I will only give you the theory and the philosophy. See, it is the worst prognostic variety I get, but sometimes it is the best in terms of chemosensitivity. The amount of responses or depth of responses you see in some cases of TNBC is very, very high. So do not think that they are not chemosensitive. Chemo sequences does not really differ from the rest. We really waft the belief, and we have seen our senior teachers also do it, and it's a standard practice in many centers, that it's a TNBC. It has to be bombarded with the most toxic regime possible, and we end up using TAC always. So that is not a standard. You can definitely use TAC. I will come in my next slide, but you can jolly well use your FEC3T3, AC4T4, or your standard chemo regimes will do. TAC is also one of them. So do not think TNBC means start hitting with TAC. No, TAC is not very easy to tackle in the doses that are recommended by the clinical trial that brought around TAC. Platinums in TNBC. Must remember the special situation where BRCA1 or 2 is mutated. Platinum is indicated in this situation, but having said that, if you do not know the BRCA status, you should at least give it a try in your later lines of adding your taxanes to your existing kitty of using a sequence one after the other. The concept of capecitabine maintenance, which Abhishek had said, believe it, it's only in the adjuvant therapy. There is nothing known as capecitabine maintenance in metastatic breast cancer. And having said that, it is also known that there is nothing known as 6 to 8 cycles in metastatic breast cancer. Our standard practice is to give 6 to 8 cycles, but if the patient is tolerating well, you continue with your standard dose of capecitabine, but do not call it a maintenance. It's not a maintenance. We should remember 3 special drugs: eribulin, which is a helicoidin B analog, liposomal doxorubicin, and nab-paclitaxel over and above the usual ones in triple negative breast cancer. So this is as a whole the philosophy that you need to know in metastatic setting for your triple negative breast cancers. And as I said, this is the drop down of all your standard therapies that you can use in triple negative breast cancer. Dose dense AC followed by T, taxanes with cyclophosphamide, FEC followed by T, EC, TAC, AC followed by docetaxel, CMF. Everything is allowed. You can use any of the standard regimes. It is not that it has to be a TAC upfront. So that's your TNBC. Having said that, let's look at the site-based decisions. As I said, after all your decision making, you have to understand whether it's a bone or a brain or a liver, and this will help you to understand a bone pain or a bone fracture is not a visceral crisis. May choose fulvestrant over the rest of the hormone agents in the first line, because fulvestrant has done really well in the setting of bone only meds. Remember your bisphosphonates. For a patient with skeletal metastasis, it has to be at least 1 year of bisphosphonates. Then you can reduce the frequency or increase the frequency of giving your bisphosphonates. For a patient on AI, 6 monthly bisphosphonates, or no, that is somebody who's on anastrozole or letrozole needs a 6 monthly boost or a dose of zoledronic acid. You cannot forget that. And this is absolutely basic and purely meant for the students listening to me. Denosumab, yes, it's a monoclonal antibody against the osteoclast, but remember, for your nephro-compromised patient, this is the treatment of choice, because the bisphosphonates will compromise the renal status more. If somebody is already nephro-compromised, they can go ahead with denosumab. It also has an ease of administration. The patient does not need to take IV medications, because bisphosphonates, that is your zoledronic acid, has to be given IV, whereas denosumab can be given subcutaneously. And of course, for the affordables, though more and more companies are coming up with them and the cost is coming down. So nephro-compromised, ease of administration, that is patient compliance, and affordability, these should be determining whether you are going to use denosumab or not. Now look at brain. If brain comes in mind and you want to give an anti-HER2 directed therapy along with a chemo, then the first thing that pops up in our mind is LAPCAP, that is lapatinib capecitabine. Here you can choose, where you have a brain mets, you can choose this regime over the others. CDK4/6 inhibitors, abemaciclib, the first thought that comes in our mind if the patient is having a brain mets. Last and not the least is liver. Do not ignore the enzyme cutoff. We do not look only at the bilirubin for the cutoffs to decide whether we give a taxane or we give something else. 1.5 is the cutoff to reduce the dose of taxanes. Above 3 bilirubin, your taxanes are not allowed. But also don't forget the enzymes. You have to remember your upper limit of normal is 40 and you can move up to 3 times. So up to 120 you're allowed. So somebody who's bordering on 110, bordering on 100 is probably having an impending liver failure coming. That's visceral crisis. Remember that. And also remember that the CDK4/6 inhibitors are silently notorious for rising your liver enzymes. So if the liver enzymes are deranged, you be cautious while using your CDK4/6 inhibitors. So special mutations, as I've already said, only BRCA1 and 2 and PIK3C will be discussed. For the BRCA1 and 2, you have to remember platinums for the BRCA mutated TNBCs. You have to remember, if BRCA1 and 2 is mutated, we have PERP inhibitors in our hands. Olaparib for the germline mutated BRCA mutated tumors who are HER2 negative. And they have progressed on 2 prior lines of chemotherapy and 1 prior line of endocrine therapy. They are the ones where the PARP inhibitor olaparib is indicated, and it's now a standard of care in that setting. If PIK3C is mutated, we have to remember alpelisib in combination with fulvestrant in the second line. So these are taking care of your special mutations. So having taken care of most of the 8 drop-down points, I would once again, before saying thank you, want all the students to understand your PS3 cuts of chemotherapy, whatever the things, but your hormones and anti-HER2 directed therapies are always there. You have to understand whether it's a de novo that is coming originally as a metastatic breast cancer, or has it progressed from the early or the locally advanced phase. Having said that, if it is has progressed from an early or a locally advanced stage, then you have to rule out what was used previously and select out your drugs accordingly. Whether the patient is in visceral crisis, irrespective of hormonal status, you have to give chemotherapy. And if ER and PR are positive, then of course and the patient is not in a visceral crisis, then you know how to go about in sequence. Remember the drop downs of the first line. All 4 can be first line now. Previously, we learned tamoxifen and aromatase inhibitors, that is anastrozole and letrozole. They were the only ones. Once you use tamoxifen, then you move on to the switch techniques or the other techniques that were used. Those are the only things we have learned, but now all of them are in first line. HER2 status is very important. We have to understand it's a negative prognostic factor being HER2 positive, but it is also a predictive factor because we have so many drugs. We initially had trastuzumab. Now we have the later line drugs, that is lapatinib, have pertuzumab in combination with trastuzumab, and at the end of it, we also have TDM1, that is Kadcyla. So HER2 status also becomes important. TNBC can be a separate book altogether. There are so many things we can discuss, but you have to understand your chemotherapy line in TNBC is purely similar to what you use in any other setting. So do not think TNBC, the toughest variety, let's start with the toughest one, and TAC is the only regime you talk of in your exams. Don't do that. Look at the drop down. All the simple regimes can also be used in TNBC. And remember, whenever you say TNBC, it doesn't respond, don't say that. It doesn't respond, do not say that. It has one of the most important chemosensitivity. Sometimes your TNBCs can respond even better than the normal ones. Site of metastasis, whether it's a bone only, choose fulvestrant, brain only, choose abemaciclib. I told you how you can select out as per the, based on the structures where the metastasis happen, and the special mutations, BRCA and PIK3CA comes in the setting of TNBC and your setting where you can use alpelisib with your second line. So having said that, I couldn't have prepared any slides based on this. This is just my philosophy, my thought, how I teach my students when you face with the metastatic disease. This is not in detailed discussions. We could have touched upon each and every point and talked about studies in details. But if you have got your philosophy wrong, you will go completely wrong. Judge your PS. Remember what visceral crisis is. I think with this, I would like to conclude my talk. I hope I didn't shoot time. If there are any other questions, I would be more than happy to take, of course, philosophically.
Okay. Okay, thank you, Dr. Kaushik, for the excellent, wonderful, summed up talk on the metastatic breast cancer treatment regimes and paradigms. So we have 3 questions directed to you, 2 from Dr. Kaustav and another from Dr. Ado. Dr. Kaustav asks you about, the first question has got 2 parts. He's asking you, how do you define visceral metastasis having a patient of multiple liver parenchymal mets having less than 1.5 times the bilirubin or 10 times of the SGO2 SGPT? I think he's asking about the visceral crisis, not about the visceral mets. If I'm wrong, maybe that's the thing he's asking. And the second part of the question is that, is it depending on the hormone receptor and the HER2 status? So this is the first question from Dr. Costa.
The first question was bilirubin 1.5, but the enzymes are 10 times.
Yeah, the enzymes are 10 times and the bilirubin is 1.5 times. Yeah.
See, that per se is a visceral crisis. I understand, but having said that, it rules out most of the drugs, not only taxanes. I think we are left around with, say, gemcitabine.
Koshita, can I interrupt? Sorry.
Yes, please.
It's my question. Sorry. So, is it whether if a patient having multiple liver parenchymal mets, but the liver enzyme has not deranged that much? Okay, that is, it is not. It is in the range you can use something. Okay. Yeah. So, is it considered as visceral crisis? I have wrongly written is visceral mets. Is it considered as visceral crisis? Because visceral crisis where there is obstructive biliopathy or obstructive uropathy, something like that, but not reached till now, but still have multiple liver parenchymal mets. Should we go for chemotherapy in those cases, or can we?
I think, see, if the liver related symptoms are not there, and you find that the enzymes are within range, and your bilirubin is less than 1.5, then you can jolly well consider this patient to be fit for hormones or anti-HER2 related therapy, and you do not consider this as a crisis. Because visceral crisis, I understand, is a combination of clinical as well as biochemical parameters. If the clinically patient is not complaining of right hypochondrial pain, there is no huge tender hepatomegaly, and you have not seen signs of liver failure, and your enzymes are within close limits or less than 100 or say within range of 90, this is not a visceral crisis. Then you can go ahead with your anti-HER2 therapies as well as the hormone therapies.
Thank you.
So his second question is
my next
that,
question, I'm just asking you.
Yes, Kosto.
Yeah. So you can ask, or will I read it out? He's asking, can trastuzumab be used as a single agent in metastatic HER2 positive breast cancer? And he adds on read it that trastuzumab is not used in adjuvant settings.
See, if trastuzumab has not been used in adjuvant setting, then I really don't remember of any data where trastuzumab can be used as a single agent. But having said that, I'll tell you, there are patients who have been tried upon. I have used single agent trastuzumab because we couldn't do anything. We didn't have lapatinib. Patient had a refractory thrombocytopenia. We could not use any chemotherapy, but the patient was HER2 positive. We kept on using trastuzumab only. But initially, few cycles had been used, then we had to withdraw the chemotherapy. So your answer is yes, but probably it is not backed by any evidence with that I'm saying.
So we have another question from Dr. Adok. He is asking zoledronic acid monthly or 6 monthly?
Simple answer, if the patient is having skeletal metastasis, then it is a monthly dose or a 4-weekly dose. If the patient is not having skeletal metastasis and the indication for using zoledronic acid is to prevent the bone mineral density loss because of an aromatase inhibitor, then the dose is 6 monthly. After 1 year, you can take a call, you can bring it down to say 3 monthly or 4 monthly, but at least 1 year, it has to be every month if the patient is having skeletal mets.
Yeah, that is very correct. I think you have actually pointed out about the prophylactic use of zoledronic acid and the therapeutic use of zoledronic acid very clearly in your talk. I think there is another question. Maybe Dr. Abhishek, if he's there, he has already answered this question. Again, the question is that could you please repeat definition of primary endocrine resistance and secondary endocrine resistance? The question has been asked from Dr. Abhay Chakraborty. Dr. Abhishek, if you are there. Abhishek?
Sorry, Shamrat sir. Abhishek, I think is not there. He has went for something work to do. So I think the question we'll send the question to Dr. Abhishek Basu and he will answer you in the meantime.
I think the slides are available and his slides were quite self-explanatory. He has described this beautifully in his slides about the primary and the secondary endocrine resistance. So I think that discussing about the breast cancer is vast, and each aspect of breast cancer will take hours of discussing, whether it's endocrine or chemotherapy, whatever. So I think we have come to the end of today's discussion, particularly for the junior residents per se. You should be very practical about what you write in your theory papers and how do you answer your viva questions. And then comes obviously your practical clinical day-to-day OPD basis. So I thank all the speakers from the core of my heart for wonderfully summed up presentations and beautifully written slides. Dr. Ritam, Dr. Abhishek, and Dr. Kaushik, all of you are great. Thank you to all of you.
Thank you so much.
I hand over to the organizers.
One small announcement that the videos of the presentations will be shared to by all the modules to the attendees only, and not that all who have registered. So please attend. We'll see the attendance before sending the videos.
Okay, thank you everyone, and we will meet again on the 30th in the next Saturday. And till then, bye and good night.
Good night, everyone.
Good night.